problem is that most people just go and do a generic mobility program where they hit a little bit of everything. And let's say your shoulder mobility is great, but your ankle mobility is awful.
Yeah.
And you're doing a generic program. Every bit of time you spend stretching your shoulders doesn't improve your ability to get into optimal positions for the movements that you're doing. And so you could take all of that time doing a shoulder mobility exercise and double down in the ankle mobility and make dramatically more progress in terms of improving your movement quality. So that's why I really encourage people to stay away from generic programs and try to get really specific with it.
Guys, thank you so much for downloading this episode of the True Sports Physical Therapy Podcast. Today's guest was Dr. Zach Long. He is Barbell Physio on Instagram. He has an unbelievable following. He is one of the founders of Onward Physical Therapy, which is nationwide. They've got clinics everywhere. He's done a great job of building up that brand. He also teaches for the Institute for Clinical Excellence, so check him out. ICE is their abbreviation. You'll hear him talk about that coursework. You'll hear him talk about shoulder issues, thoracic spine, hypomobility, how he treats those. We got into the hip, we got into the ankle as well. What I loved about this conversation is that it's real world physical therapy. Zach is the owner of a cash clinic, and he does a great job of showing that you better be good at some of these nuances if you're going to ask a patient to pay cash. So I encourage everyone listening to share this conversation with their PT buddies, really internalize it, maybe listen to it a few times so you can get all of the pearls of wisdom that Zach shares with us. Without further ado, here is Dr. Zach Long. Welcome back to the True Sports Physical Therapy Podcast. Really excited to have the one and only Dr. Zach Long with us. Zach, welcome to the show, man.
Thank you for having me. Excited to chat.
Oh, yeah. It's going to be a great conversation. I've already learned a ton as we were talking off air. So give me some background as to what your day-to-day looks like and how you got where you are.
My day-to-day is probably a little different than most PTs. I own a couple different businesses. So I have an online fitness business that's primarily for fitness athletes like CrossFitters and Olympic weightlifters. And then I also have an out-of-network physical therapy clinic in Charlotte, North Carolina that I treat out of on a very limited basis, only 10 to 12 hours a week. And then we have about 30 other cities around the country where we have Onward locations in. So I split my time between the online fitness business, doing a little bit of treatment, and then doing admin stuff with all of those other clinics and helping them grow. So it's fun.
Oh my God, that's so much. So how often do you hit your clinics across the country?
I probably see them like once every 3 years. I'm going to get to a clinic. There's, of course, could be some that I hit a little bit more frequently than that. Like I teach continuing education for a company, so I'm on the road. And so some of those cities I hit more frequently than that. But I have 2 business partners, so they're also running around seeing them. So we probably get to everybody every year and a half-ish.
Dude, that's amazing. Something to shoot for. You mentioned you have 41 clinics countrywide. So I love hearing that. It's worth calling out. And then you teach for Institute of Clinical Excellence. Just give me like an elevator pitch as to why someone should take a course at that institution.
So the common theme between all of the courses at the Institute of Clinical Excellence is being fitness forward. So by that, we mean like we want to have the skill set to keep people that are active in the gym, doing the things that fight against the bigger healthcare issues that we see across the United States and across the world. But then for people that aren't currently living that way, that aren't exercising, following good nutrition, et cetera, at ICE, which is our acronym, we look at pain as the opportunity to start to implement that stuff with individuals. So if somebody's coming to see me for back pain, but they don't exercise at all, we could give them the standard old physical therapy exercises, or we could package those exercises up inside of like a high intensity interval training session that gets, those low load exercises to create a bit of a heart rate effect so that we start to build some cardiovascular fitness. Or we could get them doing some heavy lifting. We could get them deadlifting and Romanian deadlifting and doing bent over rows, things that build stronger tissues. And we want to build fitness in those people that don't get that fitness dose in their life every day. And that's the common theme across all of our courses, whether it's a lumbar spine manipulation course, whether it's our older adult coursework, or whether it's the fitness athlete coursework that I teach in.
That's really awesome. How did you come up with that idea?
That is not my idea. So full credit, Jeff Moore is the founder and CEO of ICE. He is a phenomenal instructor when it comes to the spine. And then he partnered up with my co-instructor, Mitch Babcock, years ago to start this fitness athlete division. And then Jeff and Mitch asked me to jump in with them and help them grow that. And it's just been a phenomenally fun 8 years. Does not feel like I work a day in my life.
So that's amazing. So you've been doing that for 8 years. Onward Physical Therapy has been around for 6?
Yes.
Okay. And what was the aha moment there when you're like, hey, I'm going to open up clinics across the entire country?
As you know, like I've looked at y'all's site, I've seen your social media. Y'all do things different than most physical therapy clinics out there. And
thanks. That means a lot coming from you.
There's so many people that are running through coursework that we teach, and they get excited about taking this different approach to physical therapy, and they go back to their clinic, and they're the only one there that wants to practice that way. They're having to buy kettlebells and put them in their car trunk and haul them to and from the office every day of the week to have the right equipment to make their patients stronger. And we wanted to create a spot where we felt like people could practice exactly how we believe the best physical therapist should practice, and not have any of the burdens that we see inside the physical therapy world and the medical professions as a whole in how we operate. So don't take insurance at all.
Yep.
One-on-one. Yeah.
Yep. Okay. So no insurance. So it's cash-based practice. One-on-one. How long are sessions?
An hour long.
An hour long. And how do these therapists get patients? I think if I'm thinking about like way back when I started True Sports, some of the worries that I had, one was, can I spend enough time with my patient? Another one was, could I do it in the right facility? A third was, I need patients and athletes to treat, so I got to figure that out. How does Onward solve for that?
Our biggest belief in terms of getting patients is you want to treat the people that you're going to be most on fire to treat long term. And usually for people, that is treating other folks like them. So like, what do you do for exercise yourself?
Yeah, I'm a lift guy, so I'll do barbell work 3 to 4 times a week. I'm a Peloton guy 3 to 4 times a week.
So you're probably in a gym lifting 3 or 4 times a week. So in that gym, you're developing relationships with people, you're developing relationships with the coaches or personal trainer at the gym. And that's going to naturally result in you doing things like workshops at those gyms. So really the biggest thing people can do to see more of the people they want to see is just to regularly be part of that community and whatever that community is.
Yeah. So how does Onward facilitate that?
In terms of that, man, it's really just sitting down and strategizing, like, what do you most authentically love doing? And then how many gyms in your area do that? And how do you kind of narrow down which of those gyms you want to spend most of your time in? And then figuring out in that gym, what are the unique needs that gym has? So it's really about the organic local relationships. I mean, Onward, from an HQ perspective, we do a lot of SEO work and back-end work on people's websites and things like that. But, you can't shortcut developing relationships with people long-term.
Yeah. I think there's a lot of gold in that statement, a lot of knowledge and wisdom in that statement. So if you're listening at home, write that one down. I think it's all about grassroots. Like, that's how you're going to fill your schedule. That's a huge piece of it. That other ancillary stuff is a great reason to join an Onward or a True Sports to help on that side of things. So I think that's awesome. Who doesn't fit in the Onward model? Give me an example of someone who's joined Onward and like, dude, this just isn't working.
I'd say people that aren't obsessed with clinical excellence are probably not going to do really good in this model. It's something that everybody on the team is insanely passionate about. Like, just this past weekend, we had all of our owners got together in San Diego for a weekend full of diving into clinical skills and just trying to be better. So that would be number one. Number two is going to be people that aren't fitness forward. So if you don't want to, exercise several days a week and eat well and take care of your body, you're going to stick out like a sore thumb, and you're just not going to enjoy hanging out with us, because we are people that are obsessed with that stuff. Those are probably the two biggest characteristics of people that are going to do well or not do well inside of our model.
Yeah. You raise a good point. When I eventually got out of the cookie cutter system and moved into, we treat on the 45-minute, but if you're working in 45-minute to an hour type session, it's totally different from a standpoint of, you have to know from beginning to end how you're going to fill that session. I think it's a unique skill that gets lost on some newer grads, where it's like, I want to treat for an hour, I want to treat for 45 minutes. well, what the hell are you going to do for that amount of time? And that learning curve, I think, is a big piece. So it's worth kind of calling that out.
It's interesting to watch people, like when we hire somebody that's worked in more of a traditional clinic, to watch them figure out how to fill up an hour of time. Those first few weeks, they're just like, they're at minute 50 and they're like, what do I do? Because they're just, it's not even like, if you go from 30-minute sessions to an hour, it's not double the time with each client. It's more like triple the time when you add in like the time you spend bouncing back and forth and how you're never 100% dialed in on that patient in front of you. So it's quite a bit different to go to one-on-one for an hour or 45 minutes like y'all are doing. It's a lot more to manage than people think of prior to jumping in.
Yeah. Like I see newer additions to the team, like looking for the ice pack, at minute 40, when it's like, that's when they would standardly do it, right? Like trying to coach them out of it, and putting together systems to teach them how to do that. How do you fill your hour effectively? I think that's something that Onward probably does a great job of. I want to dive a little bit into the clinical world. So you said, actually, before we get there, you said you still treat like 10 to 12 hours a week.
Yes.
What do you do when a new athlete calls you and says, hey, just had an ACL, want to rehab it with Zach Long? What do you do with that phone call these days?
I'm in a very great situation right now where I treat the exact people that I love to treat. So I treat CrossFitters with shoulder pain, hip pain, and like back pain with deadlifts.
Yep.
So to be honest with you, somebody called me up with a post-op ACL, they're probably going to see somebody else on my team that loves that a little bit more.
Yep.
We are at a good enough size in our clinic that we can really try to fit people more with the person that's most on fire about treating that condition, which I love, because like that's what makes your career more sustainable, is when you're narrowed down to the things you're most excited about. So I'm probably not going to see much of that immediate post-op ACL. I will occasionally see some that are, 3 or 4 months out. But Yoni, dude, I think mobilizing somebody's knee to try to get to 0 degrees of knee extension and a few degrees of hyper and helping them turn their quad back on, I think that is boring.
I love that stuff, but I get it. I totally get it. But that's why you should send them to me, right? And I'll send you all the CrossFitters. So that makes a lot of sense. How do you actually handle the conversation? Because I talk a lot in my clinics about the art of the handoff and doing it well. What makes a great handoff at Onward?
A great handoff really comes down to speaking praise about the person they're going to say, being willing to say when it's not your thing that you do and are best at, and just being willing to say, hey, Holiday here is phenomenal with runners. Like her understanding of running assessments, of footwear, of training volume, of all of these things just so far exceeds me that while I can do a good job, she is going to do a phenomenal job.
Yeah.
Really talk those specific aspects of it.
Yeah, that's really great. That's a great nugget, and I think I think a lot of PTs get territorial or maybe insecure about praising those next to them. But you're right, that goes a long way. My line is, I'd love to treat you. This therapist is way better than me. Here's why they're way better. They'll take you all the way to the end. So I love to hear that that's going on at Onward. Okay, now to get a little bit more clinical, you talk a lot about wasting time on generic mobility drills. How do you get super specific with diagnosing a mobility deficit and then prescribing your intervention?
Yeah, so in the CrossFit space, CrossFitters train movements that move the body through more range of motion than most recreational fitness activities. When you think about something like an overhead squat or a tipping pull-up, we expose our body to more motion. And over the history of CrossFit, people have understood more and more that having good mobility allows you to get into better positions. But the problem is that most people just go and do a generic mobility program where they hit a little bit of everything. And let's say your shoulder mobility is great, but your ankle mobility is awesome. Sorry, your shoulder mobility is great, but your ankle mobility is awful.
Yeah.
And you're doing a generic program. Every bit of time you spend stretching your shoulders doesn't improve your ability to get into optimal positions for the movements that you're doing. And so you could take all of that time doing a shoulder mobility exercise and double down on the ankle mobility and make dramatically more progress in terms of improving your movement quality. So that's why I really encourage people to stay away from generic programs and try to get really specific with it. How to figure that out is really working with somebody that either understands your sport and can help break that down for you, or like I've got a resource on my website, one of my websites, performanceplusprogramming.com/movements, which is for mostly CrossFitters. But you go to that website and you say, I'm struggling with my overhead squat, I'm struggling with the deadlift, whatever it is. You click that exercise and I'll run you through different tests so that you can actually figure out where you need to focus your mobility so that you waste less time and make faster progress overall.
Yeah, be a sniper instead of a carpet bomber. That's great advice. Yeah, and trying to get specific. So let's dive in with that. Say a patient is having issues with an overhead squat, right? The fullest of full body movements. How do you dissect ankle mobility issues versus shoulder mobility issues? And what tests specifically are you using to do that? And then what interventions are you using to correct for those?
So to me, that kind of really comes down to like, where are you at in terms of your understanding of that movement pattern? When I watch somebody overhead squat, I can screen with like 90% accuracy whether this is their ankles, their upper back, or their shoulders, just because that clinical pattern recognition of watching thousands of people perform that movement and then do the specific test lets me bypass having to test everything out. But if you're not there and you haven't watched tons of people overhead squat, then you have to think through all the different components that could be impacting that, which could be ankle mobility. That's one of the huge ones with it. Hip mobility is important, not quite as important as ankles in the overhead squat. Thoracic mobility is important, and shoulder mobility is brutally important. The amount of shoulder flexion you have crushes or really helps the overhead squat. So if I watch somebody overhead squat, for example, and their torso is really leaned forward, what you might see is that their shoulders are in this like really extreme position behind their body. For me, having watched 1,000 athletes overhead squat, I'll instantly recognize that I probably don't need to test that athlete's shoulder mobility. They've got it and then some. And I'm thinking something further down the chain must be off that's forcing them to use their shoulder mobility a little bit more. So I can bypass it a little bit.
Okay, so that makes a lot of sense. By the way, you make a great point. It could be that this athlete has a in that example you named, they have a restriction in T-spine mobility, and so they're compensating with their shoulders, but now their shoulders are at risk because it's too much motion. They're no longer in a stable position. It's worth thinking about, where do I also need to stabilize, not just mobilize? But okay, so in that instance, maybe it's T-spine, maybe it's ankles. Do you then break down specifically, okay, I see those deficits, now let me test and tease those out? And what tests do you use?
Yeah, absolutely. So see that deficit, that's going to lead me to thinking of T-spine or ankle mobility, most likely being the deficits there. In terms of the tests that I use, again, you can look all these up on that website I mentioned earlier. I like tests that are fast, but accurate and easily reproducible. So I don't often pull out like a goniometer just because I think it wastes a lot of time. And also for something like ankle mobility, like going back to PT school, they were saying with that goniometer, like keep that one line of it, that one arm in line with the fifth metatarsal. I'm like, well, I know where the fifth metatarsal is, but like I can't really see it. So I never felt like I was actually that massively accurate with the goniometer. So ankle mobility, I love just testing closed chain dorsiflexion down in the bottom of a lunge. How far over their big toe can they push their knee? Thoracic spine mobility wise.
Hold on 1 second. What's their goal there? What's normal?
Ideal for me is one hand width away from a wall, and I just measure how many fingers away from a wall they are. I do that because I'm 6'2", so my hand is wider than if somebody was 5'2".
Yep.
And it maybe sort of standardizes it, but it's important to recognize even with that like if you fail that test, it doesn't necessarily mean that you have to get after it. It just increases the likelihood that I do, and so much of that comes down to like the science of being able, or the art of being able to analyze that movement. That's like one of the things that we really cover in our fitness athlete coursework through the Institute of Clinical Excellence. But yeah, one hand width is kind of my goal there.
Okay. So now you were going up to T-spine. Talk to me about that.
T-spine, I really like the lumbar locked thoracic rotation test. That's from the selective functional movement assessment crew. So you start on hands and knees, you sit your butt back onto your heels, put your forearms together right in front of your knees. So when your butt's on your heels, your lumbar spine is flexed, so you're not going to get much lumbar spine motion. You then put one arm behind your back and you rotate your spine. And so if you're rotating with your lumbar spine locked, most of that rotation is coming from the thoracic spine. And you're really looking for, without getting any side bending, can you get about 50 degrees of rotation up? So I'm kind of measuring along somebody's collarbone for that.
Okay, and you're measuring, now you're using your Goni?
That I eyeball that one. Yeah.
Okay, so you're eyeballing that one. And the reason you're using rotation as a substitute for extension is because it's a compendium of a piece of same-sided facet extension if we were in a textbook. Is that why we're using rotation?
Yes. So if one side rotation is limited, extension will also be limited by the way the joints move. There's not a good way to isolate just the extension of the thoracic spine that I'm aware of.
No, I'm totally with you. And I think that makes a lot of sense. And I love that you're eyeballing it. So far, you have identified mobility restrictions without using a goniometer, which supports my theory that grad school wasted a lot of our goddamn time, didn't it? I mean, Jesus.
There are times to be really specific, but I think a lot of times it gets a little too detailed.
Yeah, in the clinic is not one of them.
Most of the time, too, when you're talking about fitness athletes, usually they're pretty low irritability. And I think a lot of times when they're low irritability, figuring some stuff out is a little bit easier than when they're high irritability, and getting to the good stuff, the movement, the treatment a little bit faster is a lot of times nice to do.
Yeah, totally. I think that's real world experience and knowledge. So super helpful. Okay, so now let's shoot back down to the ankle. So they're missing active closed chain dorsiflexion based upon your knee to wall or based upon your closed chain dorsiflexion test. What do you do about it?
Well, the ankle mobility is one of the areas that I think is often toughest to get mobility back in, because a lot of times when somebody's stiff there, it's like a former basketball player or sprinter that's just done thousands of reps of bouncing on that Achilles tendon that just has a lot of stiffness to it. So I tend to find myself doing heavier, longer duration stretching with ankles than I do other areas of the body. For example, like if I have somebody that I think is just a really, really stiff ankle, almost imagine a seated calf raise machine. Yep. But I do that with a barbell on somebody's lap because most of my clients are CrossFitters that don't have access to a seated calf raise.
And you're the Barbell Physio.
Yeah. So put that barbell on their thigh as if you're in a seated calf raise and just hang out there for a couple of minutes. Let that weight put some significant time under tension on the ankle. Now, I would not do that with the shoulder. Like, I love dumbbell pullovers for shoulder mobility, but I'm not going to give them a 95-pound bar and have them hold that in range on the shoulder, because the shoulder tends to open up a little easier than the ankles. That would be a riskier, that'd just be a gnarly exercise to do on the shoulders. Yeah, it works really well on ankle mobility.
Okay, so that's awesome. Now, does it matter to you whether it's an active restriction or a passive restriction in terms of that intervention at the ankle?
It does, but usually when I'm watching somebody perform a movement like the overhead squat, if they don't meet my points of performance for that movement, I don't immediately start assessing how those joints move. I want to take a coach first mentality. So I will watch them squat. And let's say in the overhead squat, I'm not seeing their knees travel forward as they drop down into the squat. Maybe they really initiate the squat by sitting their hips back and sitting back.
Yeah.
Instead of immediately starting to test their ankle mobility, I will actually spend a minute trying to coach them into better positioning.
Yep.
So instead, I'll say, it looks like you're really aggressively sitting back in your squat. I want you to imagine there's a toilet right between your heels, and I want you to sit right down onto the toilet. Mm-hmm. And if they do that, they'll push their knees forward and their hips will go back. And that will oftentimes screen out that active versus passive. Like somebody that has the mobility but just doesn't use it.
Yep.
I find you can really quickly coach them into better positioning and then not waste your time doing those mobility tests. And you clean up somebody's technique, you get rid of their pain faster, and it's just overall more effective. So I watch somebody to see if they hit the points of performance for that movement. Then we coach them first.
Yep.
Then if coaching doesn't help, we start to break down the specific joints and muscles that might be impacting that.
Okay, so take me all the way there. So coaching doesn't help. Now where do we go? So now we go into this passive intervention, right? Which is your seated barbell ankle stretch. I'm sure you have a better term than that. What else are you adding to that?
So what I would do, watch the movement, identify the faults, coach them. If that fails, then assess the joint. So if we were thought that the ankles were a little restricted and that was what was driving their issue, let's confirm that. So let's put their heels up on a 10-pound bumper plate that gives them a little bit of fake ankle mobility.
Yep.
And then have them go back to that movement pattern. And if the movement pattern now looks better, we've really proven, like we've closed the loop here, that if your ankle mobility is better, your squat's going to get better. So now we then go do the exercise, like the seated calf raise stretch thing.
Yeah.
I oftentimes like to pair that passive mobility with then strength or working on them using that mobility that we're opening up. So we might do that seated calf raise and then something like a tempo goblet squat, where they're really thinking of trying to push their knees forward, which is the advantageous position in the overhead squat, as they descend down. Because so frequently you'll open up mobility, but this athlete hasn't had it for forever. Mm-hmm. So if we don't kind of teach them how to use it and build strength there, they're kind of just going to squat the way they've always squatted.
Yeah. Yeah. Or worse, you're given a motion that they can't control and you're opening up the door to other issues. So that makes a lot of sense. Are you worried about any other, because you've only really mobilized in the sagittal plane, right? Do you care about mobilizing the ankle in other planes of motion or teasing that out?
Yeah. A lot of times people lack I just generally categorize it lateral ankle mobility. So there's like lateral tibial glide as one test for that. Chris Johnson, well-known PT out of Seattle, has a phenomenal test called the table test. I can't even begin to describe how to do those here. But those tests are really good. And oftentimes when those are limited, I will actually address those first before I go after straight ankle dorsiflexion. So like really two really common patterns I see in the clinic is when lateral ankle mobility is limited, you can't easily restore ankle dorsiflexion. And when the posterior shoulder mobility is limited, it's hard to restore shoulder flexion overhead. So when those are limited, I go after those first.
Okay. How do you go after those?
Which one?
How do you go after lateral ankle restriction?
Let me see if I can explain this in a way that'll make sense.
Use your words, Zach.
Yes. Imagine being in the bottom of a goblet squat. You're holding a light kettlebell and you put your forearms right on your vastus medialis. You let that kettlebell kind of pull your knees forward, and then you pry your elbows out as you let those knees come forward. And so by doing that with your feet locked on the ground, you're going to drive some of that lateral ankle mobility and straight ankle dorsiflexion. That's probably the way I use the most to get after it.
Okay. It's amazing that you have not mentioned. So first of all, great answer and great description. That didn't sound so difficult for you to articulate. You have not put your hands on the patient from a treatment perspective. Is that by design?
In that example, when I get to doing mobility exercises, more frequently, I actually am going to be jumping in on a manual perspective there. And I'm going to mobilize one thing, get back to the functional movement that we're trying to change, and retest it.
Yep.
If it has a positive effect, then I'm saying, awesome, what I just did, improve that. Now let me show you exactly what to do that yourself.
Yep.
So that, I mean, the Twitter crowd of physical therapy is all anti-manual therapy because it creates patient reliance on it, which I think is utter crap if you actually know how to talk about doing it. And which is that way. I did this thing. Things felt better afterwards. Here's how you do that thing.
Yep.
Done. No patient reliance on that.
No, and I, by the way, that's a massive differentiator between what we do, and I would lump them all in one bucket, is the Chiro world, right? Like, I fixed you, you have to come in repeatedly so I can continue to fix you. The way you just differentiated that is, I fixed you, I will now show you how to fix yourself. Call me with your next injury, or, join our personal training model, whatever it is. But I think that's so important, because that actually creates buy-in and turns your patient into a mouthpiece to generate other referrals. Whereas, when I start hearing patients who have been going to their chiro for the last 3 years, it creates the opposite effect, where they haven't taught me anything, they haven't solved anything. So I think that goes a really long way. Okay, so that's our ankle world. Talk to me about, you compared posterior ankle stiffness to posterior shoulder stiffness, I believe. Let's trace back up to the shoulder, my favorite joint in the human body. Tell me what tell me what you're talking about there. Let's go to overhead squat. So where they don't have all that motion, where they're able to compensate for stiff ankles, but they're leaning forward, barbell is staying anterior. What are you doing with the shoulder there? How are you assessing it? How are you treating it?
So you said they have good ankle mobility?
Good ankle mobility. You're thinking shoulder is their primary issue.
Okay. Yeah, a lot of times I see posterior shoulder mobility limiting shoulder flexion range of motion. So I assess posterior shoulder mobility with the Tyler test. You do the Tyler test?
No, I don't think so. Tell me what the Tyler test is.
Clients lying on their side, you have their arm in a neutral degree of rotation, horizontally abducted. You pin their scapula in retraction, and then you drop the arm across into horizontal adduction. So by pinning the scapula, I'm now assessing how the humerus moves on the glenoid.
Yep.
If the upper arm gets to where it's parallel to the ground, posterior shoulder moves well. But you'll very frequently find that people lack a ton of motion there. And you'll find that when you open that motion up, you don't even have to stretch shoulder flexion, and it will get a lot better.
Yep.
So the Tyler test is how I assess it. How I treat it, sometimes that's posterior joint mobilizations. A lot of times I do cupping on it, and you see really fast changes with one of those two. And then I love the sleeper stretch and variations of it. A lot of physical therapists hate the sleeper stretch, and I really think it's PTs that don't know how to do the sleeper stretch.
Okay, dive into that, because I was going to call the Tyler test the Reinhold test, and Reinhold has made a career discussing the sleeper stretch, its positives and negatives. So tell me about how to properly do a sleeper stretch, and where people go wrong with it.
So people don't like it because it reminds them of the Hawkins-Kennedy impingement position.
Yep.
The difference is when you do the Hawkins-Kennedy, you're not stabilizing the scapula, you're not staying in retraction, and you're not pre-biasing the posterior shoulder by rolling towards it. And so that results in somebody going through a lot of internal rotation of the shoulder and irritating. What I find is when you lay on that stiff side, you retract the shoulder blade underneath you. So you're actually laying on the lateral border of the scapula.
Yep.
Then you roll towards that arm. That pre-tensions the muscles on the backside of the shoulder. Then you finish it with shoulder internal rotation. They won't have to internally rotate very far to get a good stretch in the backside of the shoulder. Think of this as doing a cervical spine manipulation. We don't take the neck and just crank it into rotation. You put some side bending on, and you add in these secondary levers before you do a manipulation. And then you don't need as much rotation to produce that movement pattern. We're doing the same thing in the shoulder. The retraction and the forward roll, which adducts the shoulder, adds secondary levers so we don't need as much internal rotation. And I find that most of the time, that makes the sleeper stretch not feel that anterior pinch that a lot of people feel when they do it if they're not lined up properly. Now, if it creates the anterior pinch and not a stretch in the back of the shoulder, they're not ready for it right now. And that's not a big deal, but I usually find that most of the time I can get people to do that.
Yeah.
So
Yeah.
I either do like the sleeper stretch, or I really love doing eccentrics here. So we get in that position, but we have a band down past their feet, and they do a slow lower into that position with the band, and then use both hands to lift up so that I get posterior cuff strength at the same time that I get it stretching it out.
I love that. That's a great intervention. So you're stacking restrictions, right? Like that's your C-spine analogy, right? Where you're pre-tensioning things so that you don't have to go into it. Now, say that if they've got a really hot anterior shoulder, like you mentioned, a lot of times they'll feel it. What's your pivot there?
My pivot there is usually to go just into some just soft tissue work on the posterior shoulder, like lacrosse balling it, or maybe just stretching into just straight horizontal adduction and not in as much internal rotation so that it doesn't get irritated. It's that final step of the internal rotation that usually bothers somebody.
Yeah, and talking about Reinhold, I think there's an interesting study that him and Wilk put together looking at cross-body stretching and its effect on shoulder internal rotation is equal, if not better, than a straight sleeper stretch. So I think that you can make a lot of gains there. Okay, so once you stretch out that posterior shoulder, now you're throwing them back into that overhead squat to see if it's better?
Usually, yeah. Following
Okay.
the test model.
Okay, and then what is their take home? What are you giving them for home?
A lot of times in that situation, it could be, we could just isolate opening up active strength in shoulder flexion. So they could do a prone PVC pipe lift. So they're laying on a bench, holding the PVC pipe, just working on strength going overhead in combination with whatever sleeper variation I gave them. Or if it's somebody that's lower irritability, maybe I am having them then overhead squat or overhead squat with bands. So imagine me standing here, but bands are in front of me and I'm having to open my shoulders up as an overhead squat, some variation like that.
Yeah, where you're strengthening your posterior chain, you're strengthening your posterior shoulder to better hold your humerus into proper glenohumeral positioning.
Correct.
Okay. That makes a lot of sense to me. Is there any piece of, number one, cueing around what they're doing with their hands on barbell when doing their overhead squat?
The only cue that I use is to press up into the bar. So I'm not cueing them to, you'll hear people talk about doing specific things with the shoulder blade in an overhead squat. You'll hear people talk about different degrees of rotation in the overhead squat. Greg Everett, who's one of the best minds in the Olympic weightlifting world in America, has a great article where he breaks it down and he shows videos of Olympic weightlifters in America versus Chinese. And the Chinese, they emphasize internally rotating the shoulder. Americans emphasize externally rotating it. And he shows all of these pictures. And despite them cueing something different, they're all in the exact same position.
Okay.
So I try to not overcomplicate it besides saying press into the bar, like just keep an active shoulder. And that's usually the only cue I ever give somebody shoulder position wise with their overhead squat.
How do you, like, I'm thinking about like what you just showed is a well-supported glenohumeral joint as they push up and out into bar, right? How do you avoid a shrug and bringing their shoulder close to their ear when you say push up into the bar?
Put weight on the bar.
Just put enough weight on the bar that they can't feel it.
Yeah. I don't see that being a huge issue in my population where they're, even with like an empty barbell or PVC pipe, where they're actively shrugging up. I just say, don't let the bar crash down on you.
Yeah. Okay. So that makes a lot of sense. And then any other accessory exercises towards that overhead squat as it pertains to the shoulder that you see translate well and get them out of shoulder pain with an overhead squat?
Love PVC lifts, love things like a face pull Y press, which is pressing overhead. Those types of movement are my bread and butter and what I'm using most of the time.
Okay. Are you doing any waiters carries, anything like that? Anything single arm kettlebell, like upside down kettlebell work, Turkish get-ups?
I'll do weighted carries in arm bars a lot.
Yep.
I don't do a whole lot of Turkish get-ups. I'm not saying they're a bad exercise, but I think the only thing that they're good for is shoulder stability, and they take a lot of time to teach.
Yeah.
And I think I can get the exact same benefit out of a single arm overhead carry or a kettlebell windmill or a kettlebell arm bar, and it takes 20% of the time to teach compared to the Turkish get up.
Yeah. Okay. So I think that makes a lot of sense. I certainly understand. It's taken me a while to get good at treating or teaching the Turkish get up. So
I've seen really good instructors, like the gym I've been going to lately. They have some really good coaches in terms of the Turkish get up. And even though they're great and really experienced at coaching it, about a third of the time I see them coaching somebody, it's taking them forever to do it.
Yeah.
So to me, I just don't think it's worth the time a lot of times to get through it.
Yeah, yeah.
I know
Okay.
that's a hot take, and a lot of PTs are going to be upset by that. That's okay.
I don't know. I mean, I think like it's if you've ever tried to teach it, it's super complex. There's so many moving parts. If you don't know how to break it down, if you have a motor moron, it can take a lot longer, obviously. So I think it's a valid point. I'm not offended by that, Zach. It takes more than that to offend me. Okay, let's shoot to T-spine because I think this is, I love that you brought that up. I think it's so poorly understood from an intervention standpoint outside of Leon Tula cross balls. So walk me through your treatment strategies when you find that SFMA rotation test to be problematic. What the hell do you do about a stiff T-spine?
There are a ton of ways to mobilize it. I mean, you could get on your lacrosse ball. You can do foam roller thoracic extensions. You can do dumbbell pullovers on top of a medicine ball. There are a lot of different ways to get after it. From a manual perspective, have you played with body tempering yet?
I have not put it in. No, no, I know what it is. Yeah, it's terrible.
I love now for context here. I treat a lot of meatheads,
Yeah.
bigger CrossFit athletes, power lifters. We're like mobilizing that T-spine is a lot of work. So I just like to body temper their thoracic spine. That's my preferred method of manual.
Tell everyone what it is and how to use it.
Think of taking a foam roller made of steel and rolling it on people's body. That's the best explanation of it. Those are my kind of preferred manual or stretching things. But I really love in this area, especially building strength, because so many of the movements that fitness athletes do require a lot of strength in the thoracic spine extensors. So doing front rack carries, Zercher squats, Zercher lunges, hugging a medicine ball, rounding your thoracic spine, extending your thoracic spine, just different movements like that make a great 1-2 combo when somebody's stiff in their thoracic spine. Or a lot of times you'll find people that when you watch their heaviest front squats or heaviest cleans, as soon as they catch the weight, their upper back rounds and they miss the weight because of that. So I do a lot of strength work in the thoracic spine. It's just one of those commonly missed areas.
Yeah, for sure. Also, the way we live our lives is so rounded and so forward. When we ask to go into the reverse, I'm not surprised that we see so many deficits there. Are you ever manipulating, grasping, needling T-spine?
I manipulate the T-spine a ton. So you got neck pain, if you got shoulder pain, if you have thoracic spine pain, I'm probably going to manipulate it. It takes such little time.
Yep.
So even if it has a very small effect, it's not much wasted time. I don't grasp in that area a whole lot. I cup the lower thoracic spine and the lumbar spine, myofascial decompression a lot there. Needling, not a ton in that area, to be honest with you. But I also, just to be clear, I don't treat a whole lot. I don't treat almost any neck pain. Everybody in my office knows to not put necks on my schedule because I hate it. So outside of shoulders that have a really stiff thoracic spine, that's not like the area that I do a ton of manual with.
Yeah. Okay. That makes a lot of sense. And I think that gives us a lot of tools to use when looking at the T-spine. I think it's a great point you make about intersegmental mobility and strength, like you mentioned, kind of with the med ball hug and forward bend and extend. That goes a long way. Reverse hypers, I think, could play a big part here, or even like hinging, like moving that hinge up so that you're going over a fizz ball, so you're isolating T-spine's ability to extend can go a long way. And then, like you said, not just the strength, although you said strength, but also the endurance of those muscles that you'll see with the Zercher carries goes a long way. I think we fall into this world of 3x8, 3x10. So often we forget about the endurance requisites of that muscle. So I think it's worth thinking more like a strength coach there than it is like cookie cutter approach that we fall into. Okay, what do you want to add about the hip that I think is poorly hit on and so vital in some of the movements you're talking about?
Personally, the thing that I see the most with hip pain is people that have hip pain because they have poor ankle mobility. So in the squat, the squat is a continuum between the ankle and the hip. The more ankle mobility you have, the less hip mobility you need. The more hip mobility you have, the less ankle mobility that you need. And so a lot of times we just get hyper fixated on their hip hurts, so let's jump into the hip. So make sure you're assessing somebody's ankle mobility. And then for me, I treat a lot of hip impingement. I treat a ton of rotator cuff pain, shoulder instability, number 1 and 2 for me. Number 3 is hip impingement. And I tend to bucket hip impingement people into 2 different categories. You have the truly stiff hip. And to just be stereotypical here, this is men. Like you do a hip scour test on them and they just don't have a ton of mobility in their hip scour test. Their internal and external rotation is limited and tight at in range. And that, especially internal rotation, produces their pain.
Yep.
On the flip side, I see a lot of women with hip impingement symptoms. So the bottom of the squat bothers them. But when you do a hip scour test on them, they've got all the motion in the world.
Yeah, they're
and
hyper.
when you do you look at their hip internal rotation, it will produce their symptoms, but it will be an open infield. And then you do the right stuff on their hip, and all of a sudden they'll go from 10 degrees of internal rotation, turning their hip pain on, to 40 degrees, 60, 70 degrees. And so those are people that I think in my head are more unstable in their hips. There's a good research article to check out if you want to dive into this. It's called Micro Instability of the Hip. It does exist, is I believe the title of that one. For those individuals that are hypermobile in their hip but have painful hip impingement, for me, one of the best things we can do is not do what I see so often online, is that's people doing lateral distraction work on their hips. That hip already has enough mobility. You don't need to open it up more. Now, the stiff hip, that guy that has hip impingement, yeah, that might be a really great effective treatment for him. For the girl with the hypermobile hip, that a lot of times makes stuff feel a little bit worse. So for them, I tend to do a little bit more, I call it posterior capsule stretch of the hip. Just really working on, for lack of a better term, and I know somebody's going to hate that I'm going so biomechanical on this, I'm trying to push the head of the femur a little bit deeper into that socket. That or inferior mobilizations tend to do really well with them. And then it's about strength and control. So I do a lot of, like I'll superset a hip flexor exercise with a glute exercise. We'll do things like hip cars and hip airplanes to work on their control of the hip. And the more control they get, the more their range of motion opens up, and then the more they tolerate hip flexion and internal rotation.
Yeah, I mean, great way to look at it. That's kind of the way I look at shoulders, especially in the throwing athlete. It's really simple. Like if it's stiff, stretch it, immobilize it. If it's loosey goosey, strengthen the F out of it.
Yeah.
That really sums up our profession. I think you're right. I think too often we get cookie cutter, and it's like I got to do my lateral hip mobs, and then I got to do my clamshells. And let's see if that fixes it. By the way, I had a guy named Dr. Andy Wolf. He is the Mid-Atlantic's premier hip scope guy. I had him on the pod. He was losing his mind about those who operate on the hypermobile hip because invariably they fail. And so it's like thinking about like choosing your interventions wisely when a surgeon, obviously the ramifications are that much larger. But same thing with us. Like that patient is not going to get better if they require stability and we're mobilizing the F out of their hip.
Yeah.
You know, it's kind of backwards. So that makes a lot of sense. Are you ever sending anyone to a hip scope guy? Like who are you sending there?
I actually don't remember the last time that I had to send somebody in to get their hip assessed. It's been a long time. Hip surgeries are, I believe, massively overdone right now.
Yeah, and I think it's because of a piece of that. Now, I did work with an NFL guy last week who's had both hips scoped. He's hypomobile in both. He is so thankful that he had it done. I think some of that is I gotta play next Sunday, or I gotta play next year. And so it's a different mindset. It's important to read the room and know who you're talking to. All right.
Also, just so that I don't give myself too much credit on that, my patient population, again, being CrossFitters love what they do so much that when something pops up, they run in and see me really early. So I'm not often seeing the person that's like dealt with this for 3 years and is massively impacted in activities of daily living. My people are like, dude, I'm good all day till I go to CrossFit and I have to squat heavy. And if I just limit my range of motion, it feels better, but I'm tired of limiting my range of motion. So like I have a pretty unique population that I treat. It probably makes my life a little easier.
Yeah. What are that makes a lot of sense. That's the reason I love treating athletes is because they, first of all, they stick to it, right? Because they're dying to get back, and usually they're early on that side of things. How are you teaching for home self hip mobilization? Let's say for the hypomobile hip.
For the hypomobile hip. So for me, it's always, what did they respond to best in treatment?
Yep.
So like my high irritability. Wait, did you say hypo or hyper?
Hypo.
Hypo. Okay. Hypo, that's one that I often do use some more lateral distraction work. So we get a band kind of adding the lateral distraction on the hip. And then it really goes back to what did they respond to best in session?
Mm-hmm.
So I will always take a few measurements of something that I care about. So I have some asterisk signs, mobilize one specific thing or one specific direction, and reassess their response. If things got massively better, double down on that one. Do more of it, and then give them the same thing to do at home or as close to that as you can. If it didn't get much better, test something different until you find the thing that does create a great improvement in whatever those asterisk signs you're tracking are. And it's that simple.
Yeah, that is super simple. Okay, more globally speaking, CrossFit has had a tough run, I'd say the last 5 years or so. Talk to me about where you see the future of CrossFit, and how that may affect the way you practice.
I don't think it will affect the way I practice. For people not aware, over the last few years, between the founder of CrossFit leaving and 2 new CEOs coming in, there's just been a lot of turbulence inside of the organization. Then there was a death of an athlete at the CrossFit Games last year. And so there's just a lot of people really frustrated with the leadership at CrossFit headquarters. And a lot of people get really focused on that. But if you walk into, the CrossFit down the road from you, very few people there care about what's happening at the HQ level. They just care about getting in, getting their workout in, seeing their friends, getting on with their day. So I don't really see a massive change in the day-to-day operations of CrossFit. Now, I do think there's going to be more and more CrossFit gyms that decide to deviate a little bit away from how CrossFit was traditionally done. Like we're seeing more CrossFit gyms moving away from always being constantly varied and maybe picking up on the research that we know in terms of concurrent training and splitting your strength from your conditioning. And we see gyms adopting linear periodization models at times to improve certain aspects of fitness. So we're seeing some shifts, but I think so many people get really focused on like the leadership at the top that's so far removed from the great stuff that's happening inside of CrossFit gyms in every town across the country.
Yeah, I think that's a good summation. Where are you on this high rocks world?
I am down with any form of exercise that gets people excited to exercise. I think they took some of the cool aspects of like Spartan races, like the intensity feeling that you get there. They similar to CrossFit, like they just attract to a lot of different types of athletes, and all of their movements are very approachable. And then they do it in a way that's really cool, where they got DJs there and they've got people micing up and photographers. So like everybody that's there kind of feels like they're a rock star of sorts. So I love it. I think it's cool. My wife just had a baby, and once she really gets back to pushing it again, I think we're going to have to do one together, because I'm looking at it from afar. I think it's awesome.
Yeah. I love the way you put that any outlet that is attracting athletes to be more active. Yeah. Number one, it's great job security for us. Number two, that's why the hell we got in this profession. We should go along with that. And it's just great for humanity. It's great for our patients, and it's going to keep people coming back and interested in movement. And God knows America needs more of that. So I think that
17% of the United States money is spent on healthcare. I don't care what form of exercise you want to do.
Just
as long as you're doing some form of exercise, you're not spending 17% of your money on healthcare.
Yeah. Freaking love that. Okay. Tell all of our listeners where they can find you if they don't know already.
So my personal website and Instagram is the Barbell Physio, or the barbellphysio.com. And then from a coursework for physical therapists and other rehab providers, the Institute of Clinical Excellence, and I teach inside of our fitness athlete division.
I love that. Zach, it's been a long time coming. So I appreciate your words of wisdom, your time. You taught me a ton on air, off air. I really appreciate it. Let's stay in touch. We got to get you back on.
Thanks, man. Really enjoyed it.
Yeah, great work. Everyone listening, tell us what you love. Tell us what you hated. Let me know who you want us to have on next. That's how I found Zach Long, by listener recommendation. So thank you guys so much. Share it for now. Bye-bye. Bye-bye.